it's Jenny B, NSWOC. Today I wanted to do a video on lymphedema. Now there's a couple different types of lymphedema, one being Milroy's disease, which is primary lymphedema, which I'm really not going to get far into. We don't actually have a lot of it here in North America, but it is one that, again, is usually genetic and there's some predispositions to it. There is another type, though, called secondary lymphedema. And one thing that we're actually really good at with secondary lymphedema is when we've actually, created some of the secondary lymphedema due to surgery, we're really good at follow-up and treatment with it, especially when it's related to cancer diagnosis. But there is another type that's very, very underdiagnosed and really undertreated, probably the most so in what I see in all of the wound care world, that lymphedema goes on for a very long time before someone, actually notes that this is, something that requires some treatment. So I'm going to start with the lymphatic system and how it works. So again, the lymphatics, we actually have clusters of it up in our neck, in our axilla, our armpits, and in our groin. And this lymphatic system helps to move lymphatic fluid throughout our body. The lymph system, really just the easiest way to discuss it is that it cleans out some of the impurities in our blood. It kind of runs along with our veins and our arteries, and keeps buffing things up, keeps it nice and clean. So the problem with the lymphatic system, if it becomes obstructed, then kind of the whole system does, because the whole system is actually connected. So where these clusters of lymph nodes are, if we've had a surgery in either of these areas, again, quite common with breast cancer that we have lymphedema can occur afterwards because there's been some manipulation of the lymph nodes and or removal of them, where they can actually accumulate fluid into the arms. But another very common thing that can happen actually happens with those that are obese. When they have a large pannus or a large apron that folds over top of these areas in your groin, they can often end up with lower leg lymphedema. Now, because it's not related to cancer and again, or a surgery sometimes, these are often left undiagnosed and just seen as, that this is actually just excess fat, when often it actually isn't. It's actually the obstruction of the lymphatic system, and that lymphatic fluid then accumulates in the lower legs, and again, left untreated, can lead to some pretty devastating issues. So again, that's the lymphatics that I was talking about. Now, there is staging systems that go on. I like the 1, 2, 3, 4. I think when you start with something with 0, 0 would imply you don't have it. So I stick with the 1, 2, 3, 4. So stage 1 is that we do know that you do have some obstruction with the lymphatics because you've had surgery or whatnot, and you are getting some swelling, but it does tend to go away. Stage 2 is where there is still some time where we can reverse it, but often by the time I'm seeing patients, they're in stage 3 or stage 4 where it's irreversible, and to the point where they actually have fibrotic changes in the tissue because there's been lymphatics trapped in that area for such a long period of time. This is actually a very typical lower leg that I would end up seeing, and often they are coupled with having venous disease, again because there's been venous congestion for quite some times in the lower leg. Often they have small areas of wounds, and it's very misshapen. They have a lot of fluid accumulated in the ankle as well as in the toes. One of the primary ways to actually diagnose lymphedema is through a stemmer sign. So I've kind of highlighted this second toe. You can see that there's quite a bit of fluid within that toe. So what a stemmer sign is if you're actually not able to pinch the skin on that second toe, like you would do with a skin turgor. So a skin turgor is a way we determine hydration in patients, where you just kind of go up and you pinch them, and I'm well hydrated, so my skin plops back down quite easily. But when it's very slow, and the tenting of the skin when it comes down, it's very, very slow to that. Usually that's due to a lack of hydration. Well, in this case, when we're actually trying to do a turgor, you can't actually even get enough of the skin pinch because it is actually so swollen or hydrated because of the lymphedema and the lymphatics being trapped into that toe. So that's one of the ways that we can determine whether or not someone actually has lymphedema or not. Again, taking a really good health history, understanding their weight concerns, understanding their weight goals, understanding how long they've lived with that, and sometimes often even emotional health is something very helpful to help support the patient with as they're going through different challenges, especially if they do have an extremely large pannus, and what life has kind of led them up to that point. So again, there's lots of different presentations that I will see with lymphedema. Sometimes we don't have a whole lot in the foot; those are fairly rare. Usually, you're seeing the majority of it in the foot as well, because it does tend to accumulate in the toes. This is something that's cellulitic. And then generalized wound care is really related to, honestly, how much you treat the edema. So the wounds themselves, quite often, especially if there's a venous component, will often heal as long as there's compression applied. If it has been chronic and the wounds have been open chronically for a period of time and they end up with then chronic Pseudomonas or an MRSA or MRSA in the wounds, that's when there's definitely more challenges, where again, sending them off to a clinic with a wound specialist and or physician support, it would be most beneficial. Because we do get into some other rare things like stasis papillomatosis again, and this is when we're actually getting complete degloving of the leg because of it. So again, we don't want it to get to this point. So it's really having that early detection, those discussions with patients, and when you're really seeing that bulge on the foot, when that foot is quite edematous, and again all the toes are as well, it is a really good sign that they potentially do have lymphedema. And well, what is the primary treatment for it? Well, compression. I am going to talk about one of the other pieces, which is called manual lymphatic drainage, because this is something that we can actually teach patients how to do. Again, when patients have cancer, they actually can go to a lymphedema clinic. There's coverage for that because they're under a cancer diagnosis. That's part of the problem. Some people aren't able to go into these clinics, and again, when they're obese, sometimes they're not able to travel. So being able to help support them at home, this is some of the techniques. Again, complete decongestive therapy is one of the things that physiotherapists or a certified CDT therapist can provide. Often they are PTs. But then the manual lymphatic drainage, again, is something you can teach patients to do at home. But again, it can take some time. So really what you're doing, and I'm going to do it on my arms often, again, we're going to do it on your legs, but just to give a demonstration, is the very first thing you're going to do is you're going to have the patient lift the limb. Again, if it's the leg, you can't really, but they can put it out to the side. And you actually want them to activate the lymphatic area. So where that cluster of nodes are, if it's in the groin or if it's up in the arm, you actually just want to, again, you're just going to massage in a circular motion in that area, and that's going to activate and stimulate the lymphatic area. And then all you're going to do is so if you're doing it from the groin, let's pretend it's from the groin, even though we're doing an arm, and you're going to just lightly touch all the way up. And it's literally a light touch. And it's just running your fingers all down the limb till you get to the foot, all the way down, or the arm, the hand, or whichever area you're doing. And again, you can do that for, the patients do pay for this to have done for up to an hour. So again, that's something that's usually done on a daily basis. So again, if they don't have a whole hour to do it because they can't, because it's tiring, again, they could do it in increments throughout the day. So it is one of those things that is well known to actually aid in that. But then after they've done the MLD, or again after they've had their decongestive therapy, we wanted to get into compression. One of the easiest forms of compression that I will use is something called Comprelon. There is videos that you will see earlier on that I have done on how to apply Comprelon, and there are videos on how to actually apply it through the fingers and onto the hand if you're doing it on the hand. But again, most commonly we're going to be doing it on the leg, especially in someone with secondary lymphedema due to obesity. So again, you can apply multiple layers of Comprelon. Every layer that you put on is anywhere from 20 to 30 milligrams of mercury of pressure. So you can actually use 3 or 4 if need be. And again, due to the length, you're going to start with the smaller size. So again, the Comprelon comes in, I think 4, 6, 8, 10, and 12s. So, and it's pretty cheap. Like these guys, again, you used to be able to get for about $10 online or at a medical supply store, and they can be washed and reused. They used to tell us 30 to 50 times, but I think they back that off because they want people to buy them more. And it does lose a little bit of its stretch, but it's a short stretch bandage, so it doesn't apply. It's inelastic, so we're not going to wrap too tight. It is well known that with lymphedema, we can use up to from 60 to 70 milligrams of mercury of pressure, and sometimes it's actually necessary depending on what stage of lymphedema they're in. So I encourage you to go back and have a look at Comprelon if you're interested to do it, but it's a way that the patient can actually do that on their own. So Coban is the other piece that we do use quite often. I have done a couple videos on it, but Coban is something that then nursing needs to apply. The difficulty with someone with lymphedema, they can become somewhat dependent on this. So the nurse is doing this and providing this ongoing. Yes, it will reduce the limb, but again, the end goal isn't to keep them in Coban for the remaining days. It is to reduce the limb and then transition them into another garment. Often these garments have to be custom made, and often one of the challenges is that people aren't able to afford the actual customization because they can be up into the hundreds to thousands of dollars. So I do have another alternative. If we aren't able to get them into something custom, the next thing that I will suggest people to try is a Velcro wrap. These again run a little bit more, but they're quite a bit more reasonably priced. So you're probably looking about $300, $350 for a set of these, depending on the brand. But again, with the lymphedema, it should also have a foot piece. It's quite common for people to have just the calf compression, but they should, again, have the foot piece as well when we do have lymphedema. The benefit to this is that they are adjustable, and most of them will actually show you the level of compression that they can put on it, be 20 to 30, 30 to 40, 40 to 50. I think that most of these garments go up to, and they're actually quite good at reducing once you've used the Coban for a period of time and reduced the limb. So there's other research out there, and this is one thing that fight me on, especially people that do the CDT. I'm not fighting me on. It's what's going to work best for the patient. Again, if the patient is quite obese, they can't afford hundreds of dollars in different therapies or modalities. These guys are great, and also for those that don't tolerate compression. Sometimes we're making treatment choices based on what's most appropriate for the patient versus the best thing maybe for the patient. These pneumatic compression have been around for many years. Again, there's lots of debate about them. I'm not going to get into that piece of it, but just know that it is another option, and they've actually become quite affordable for patients in past years. Honestly, on Amazon, you can buy these you can pay anywhere from $200 to $1,000 for these types of compression. And all this does is it will actually just squeeze and help to push the fluid up and out of the lower limb. So again, it is another option that patients have that isn't always considered, especially if we are trying to get them out of other garments. And as I said, when they don't tolerate compression and you're having issues with them trying to adhere to wearing it, this can be an alternative. So I hope you find this helpful. Again, lymphedema is definitely one of those challenging lower leg issues, and please, make any comments about it in below if you want any more information. And just remember, the best wound is a closed one.